Don't take it, don't. Don't take it, don't. Don't take it, don't. Don't take it, don't.
My name is Kira Epstein. I am the program coordinator for the new school at Commonweal. And we are very privileged today to welcome Integrative Oncologist Donald Abrams back to the new school to talk with Michael. And thanks to Laura Pohl and Nancy Hepp and everyone at CancerChoices for co-presenting this event with us. And we do record and produce all of our webinars. We will post them. I'm sure that CancerChoices will post them on their website. The New School website will have them, and you can also find all of our recordings on the New School's SoundCloud, YouTube, Apple Podcasts, and Spotify feeds. And thank you all for being with us today, and I think that's it. I'll turn it over to Michael.
Thank you, Kira. And Donald Abrams, welcome back to the New School, and welcome as our first keynote conversationalist for our brand new website, CancerChoices.
So pleasure to be here. Thank you, Michael.
Yeah, such a joy. And I'm going to ask Laura Pohl and Nancy Hepp to turn on their cameras so that they can join us in person for a moment. And I'm going to first introduce you, Donald, and then ask Laura and Nancy to introduce themselves. They'll be supporting our conversation. Donald Abrams, you are a beloved friend of many years. You have an extraordinary resume. You co-edited the Oxford University Press textbook, Integrative Oncology, with Andrew Weil. You were named a top cancer doctor in Newsweek and its 2015 special health issue. Prior to specializing in oncology, you played a pioneering role in the field of HIV, and you've conducted numerous clinical trials investigating complementary therapies in patients with HIV and much, much more. So I'm just so delighted to have you back with us. We've been friends and colleagues for so many years. I should add, of course, that you worked extensively with the Osher Center, and you have been an oncologist at Zuckerberg San Francisco General Hospital and Trauma Center. I think I've touched the high points.
That's pretty much me. Yeah, thank you, Michael.
And Laura Pohl, please introduce yourself.
Good morning and good afternoon. It's afternoon where I am in Virginia. I'm delighted to be here. I am 40 plus years working as an oncology clinical nurse specialist. And over that time, believe it or not, I had been interested in integrative oncology long before it was called that. And in 2016, I was approached by Michael to work on what was then called Beyond Conventional Cancer Therapies. And it's been such a pleasure to work as senior clinical consultant for CancerChoices as it's evolved over the years.
Thank you so much. And Nancy Hepp, please introduce yourself.
Thank you. I am Nancy Hepp, and I am the program manager and the lead researcher for CancerChoices. And I am delighted beyond words to be doing work that is meaningful and helping people at a deep level, and something that I just love. It's just a blessing.
Wonderful. We figured that Nancy herself has put 10,000 hours into the CancerChoices website, and wow. Laura and the rest of us have put another 10,000 into it, and that doesn't count the almost 40 years of previous work that we've done in the field. So along with Donald Abrams, we are, let us say, we're all veterans of the integrative oncology world. So Donald, you were so kind to be our first keynote conversationalist for the new cancerchoices.org website. And let me start here, because our primary goal is to, we've thought about how to phrase this, but the easiest phrasing for me is to bring integrative cancer care to everyone who seeks it. Is that, to you, a good formulation of what we're trying to do here?
Yeah, I think that, the website to me is a wealth of information and a great resource. As practicing integrative oncology still at the Osher Center for Integrative Health in San Francisco, my next new patient appointment is in January 2023, and it's now July 2022. And my next follow-up for patients that I already see is in April of 2023. And if you have cancer, that's too long a wait for a follow-up appointment. So there just aren't enough people practicing integrative oncology in the world today. We have an open position for another integrative oncology faculty person, as well as a nurse practitioner in integrative oncology. And they're not filled yet. And partly because there just aren't that many people that are trained in this field. So making integrative oncology more available to people who want to know about it is critical, in my opinion. And you've done a great job.
Donald, thank you so much. And thank you for being one of our advisors to the CancerChoices.org website. And you've made such an immense contribution to the field. When you see a new patient, what are the first questions or observations you make for new patients?
Well, it's funny that you ask. So in the old days, I used to start when I saw people face to face by saying, tell me your story. And I wouldn't interrupt. Usually a physician waits 17 seconds before interrupting the patient. I would listen to the story, and that immediately establishes the relationship between me and the person I'm seeing, which is really one of the hallmarks of integrative cancer care. It's patient-centered, relationship-based. Unfortunately, we get graded by new patients, and my lowest grade was always doctor knew my history. So now I start out by reviewing the chart and telling the patient, oh, I see that you were diagnosed with blah, blah, blah. And I tell them their story. And then I say, I want some idea as to how this impacts their life. So I do try to, tell me your story in there somehow, but so, one thing that I used to hear when I asked people to tell me your story was people would weave a story as if stress caused their cancer. I don't think stress in and of itself causes cancer, but stress is not good for people living with cancer or anybody else for that reason. It's adrenaline or epinephrine, which kills lymphocytes, the building block cells of the immune system, and it's cortisol, a steroid hormone, which is an immune suppressant. So decreasing stress is really important. Since I'm seeing patients in consultation, I'm not their primary oncologist. I tell them cancer is like a weed and other people are taking care of your weed. And it's my job to work with the garden and make your soil as inhospitable as possible to growth and spread of the weed. And people like that. And I say, so I'm going to start by looking to see how you fertilize your garden. That is what you eat and what supplements you take. And that's when I launch into my spiel about nutrition and cancer, which is, of course, my passion.
And nutrition is so central to this. As you know, our approach, and I know you share it, goes beyond nutrition and cancer to a whole set of healthy habits of living. And our basic spiel, if we put it in those words, is that if you eat well, move more, get love and support, sleep well, reduce stress, create a healing environment, and explore what matters now in your life. We call them the 7 healing practices. And I'm going to ask Nancy Hepp if she can put the healing practices up on the screen for a minute. That makes you, it tends to make you a healthier person living with cancer, right? And becoming a healthier person living with cancer, what that means is that you have better quality of life and better functional status. And what that means in oncology trials of new chemotherapies is that you have more resilience for treatment, you have better quality of life, better functional status. And in the trials, the reason why they need to track functional status or quality of life is that it tends to be associated with living longer as well as better quality of life. So when I talk to oncologists about this, it's like, this is not rocket science. You want your patient to be healthier because it enables them to complete their conventional therapies. And we know from, oodles of research that it's such a powerful indicator that really it does make a difference. Why do you think it's been so hard for oncology to recognize this isn't rocket science? Getting healthier, the science is clear. We cite the science, makes a difference.
Yeah, again, oncologists, because we deal with a very serious illness and we use very complex and potentially toxic drugs, are the most demanding of evidence from randomized placebo-controlled clinical trials, double blind. You cannot do such a clinical trial with, these 7 amazing pillars to demonstrate that this is actually working. But obviously, as you say, the performance status, what we in oncology call the performance status, how a person is, are they functional fully 100%? Are they bedridden? Are they almost moribund? That really does predict how a patient is going to respond to our treatment. So you're right that doing all these things improves the performance status of the person and makes them more likely to be a responder and somebody who's going to not only tolerate, but benefit from their cancer treatment. I do want to point out that I love the central hexagon. What is it there?
Yeah, right.
What matters most? I guess I do that when the last things I ask my patients before I examine them in the old days, what brings you joy? What are your hopes? And where does your strength come from? And I think that is getting to that issue in the center there. And, once I was asking a patient those 3 questions, and her husband looked at me and said, what, is she being interviewed for Miss America? But then I saw a woman at a conference who told me that her husband had died. But when they came to see me and I asked them those 3 questions, he appreciated that even though he was where he was on his journey, he still had joy, hope, and strength. And she said that really meant a lot to the rest of his life. Mm-hmm. So I think that's the way I get to that central hexagon. What do we call it? 1, 2, 3, 4. Yeah.
Yes, no, to what matters now. So, Nancy, I'd like to ask you to move to, something in the site that we're really honored to have put up, which is our search therapies. We have over 60 different therapies. And I've asked Nancy, this is the review of complementary therapies, and I've asked Nancy to click on Cannabis. And the reason I've asked her to click on Cannabis, Donald, is that you are, I think it's fair to say, the leading authority on cannabis and cancer in the United States and the world. What drew you to, it's bold enough of you, Donald, to have entered integrative oncology as a field, which is really, you've been a pioneer, and to have co-edited the textbook with Andrew Weil. But of all the things that you could have done to court further controversy, because you did it before cannabis was more widely accepted, what drew you to become the lead researcher on cannabis and cancer?
Well, it was a little bit of serendipity. In 1992, when I was still more of an AIDS oncologist, a letter was sent to the director of research in the AIDS program at San Francisco General Hospital from Rick Doblin, the president of the Multidisciplinary Association for Psychedelic Studies. And he basically challenged us to do a study showing that cannabis was useful in patients with HIV, largely because Mary Rathbun, who was a volunteer in our AIDS clinic, had been arrested for baking brownies for our patients. She was known as Brownie Mary, and she was a volunteer of the year for 2 years running. She used to take our patients to X-ray, drop off their prescriptions, and bake them brownies. And she got arrested. And after her arrest, Rick Doblin sent this letter, and I picked up the gauntlet saying, yeah, okay, I can do that. I went to college in the 60s. So it took me a while, 5 years, in fact, of fighting the government. But ultimately in 1997, I got money and marijuana to do a clinical trial to show that cannabis was safe in patients with HIV taking antiviral drugs. And actually, interestingly, that was my segue into integrative medicine, because it gave me a strong appreciation of the power of plants as medicine, which then took me to the Telluride Mushroom Festival in Telluride, Colorado, a month after I had done my first ever jury duty and came home and said, I want to go to law school. But in Telluride, I met Andrew Weil, and he described the 2-year online distance learning fellowship you could do with his program in integrative medicine at the University of Arizona. So I said, I don't want to go to law school. I want to do that. And I did. Changed my life. The rest is history. When I finished in 2005, I started my integrative oncology clinical practice. So marijuana changed my life. And largely I was driven to it, by the way, because I myself had a partner die of AIDS in 1989. And he never took any of the antiviral drugs during the 3 years after his AIDS diagnosis, but he used cannabis pretty much every day. And when I got that letter from Rick Doblin suggesting that a study showing the benefits of cannabis in people with HIV/AIDS should come from San Francisco General Brownie Mary's institution, I said, yeah, because I remembered Mark and his outliving most of the other people in his support groups who did take the available antivirals at that time, and said, maybe there is something about cannabis.
It's such an extraordinary story, Donald. Nancy, I wonder if you could walk us through for a minute the remarkable way that we are looking at these things, how people can go to the search therapies function at CancerChoices.org and look at these 60 different substances, more and more of which we have up with these full treatments. So could you describe to us what somebody finds and how we've evaluated these therapies, cannabis as an example?
Yes. So with each of our therapy reviews that we have done, we offer layers of information for people, because we realize not everybody wants to drink from the fire hose. You might just want a sip. And so we offer an at-a-glance view with just a brief couple of paragraphs or so of information. And then we tell you how we rate on 7 different aspects. And if you want to see more, that is available. Why does cannabis rate a 1 for treating cancer? That's because there really isn't that much evidence of its having an effect. However, for managing side effects and promoting wellness, there is substantially more evidence of benefit available there. And we rate all the way down the line. If this isn't enough for you and you say, wait a minute, how do I know that this is modest evidence, is based on anything? We give full details in the evidence page that we offer, and you can take a look right at our summary of the study, and then you can get to the study itself through PubMed or the journal article.
Thank you, Nancy.
Earlier on, people asked us to rate, sort of like people do on Amazon. And we didn't think that was fair or reasonable thing to do, because a conglomerate rating really doesn't tell you the whole story. So that's why we rate on each of those effects of the therapy, as well as it's important to realize that when we don't have, say, all the randomized control trials, but we have folks like Donald who see the value and their clinical experience tells them that a therapy is useful, that it's important for people to know that, hey, this therapy has a lot of support in the clinical community. So that's why we rate on several levels and not just the scientific evidence.
Thank you, Laura, very much. Donald, in some of our private conversations, and I may or may not have this right, it's my memory. My memory is that you are less impressed by separating out CBD, for example, than the complete cannabis product. Am I correct about that? CBD being used frequently for pain and so forth.
Yeah, that's a good question, Michael. Thank you for putting me on the spot here. Yeah, I believe that cannabis is the medicine, the plant that has over 400 compounds, including 120 so-called cannabinoids, such as delta-9 tetrahydrocannabinol, the one that's most psychoactive, and cannabidiol, CBD, which is catapulted to the top of the most favored cannabinoid list because it's supposedly not psychoactive. If it has any benefit in clinical trials, it's been shown to decrease anxiety, and many patients like it for sleep. So something that decreases anxiety and helps people sleep, to me, seems psychoactive. What it doesn't do is get people high. And we live in a Puritan-based Judeo-Christian society that thinks being high is not a good thing. So that's why THC is sort of demonized, whereas CBD has catapulted to a $23 billion business in the absence of much evidence that it really does anything. THC complexes with the so-called cannabinoid receptor in the brain, and that's how it does its work. CBD actually changes the shape of that receptor so that it can't bind THC anymore. So it actually does decrease the psychoactivity of THC, but probably decreases some of the therapeutic benefits as well. So yeah, I'm just putting together a talk for next week, a lecture to a pain group. And some of my colleagues had a task force to determine how to treat pain with cannabis-based medicines. And they say, start with 5 milligrams of CBD and increase to 40 milligrams. And if that doesn't work, try some THC. Well, that to me is like way backwards. And 5 milligrams of CBD, homeopathy is not something I really encourage or endorse in my integrative oncology practice. But the clinical trial looking at CBD and anxiety looked at 600 milligrams. So what's 5 milligrams going to do? That's crazy guidelines that were produced and published. And in fact, I, with a colleague at Harvard, wrote the editorial sort of saying these guidelines are based on what, So yeah, I am not a proponent of CBD. It's in my pet store. It's when I check out at Whole Foods, it's right there, a whole tray full of CBD products. I mean, where did the evidence come from that this does anything? I mean, people do benefit, I guess, but some people actually get dysphoric reactions because it's maybe changing the shape of that receptor so it can't bind with our own cannabinoids that the body makes all the time to help us modulate our response to pain and, deal with our moods.
Well, this is so fascinating, Donald, and you're speaking really as one of absolutely the leading authorities in the field. So you're not blowing smoke. Let's just put it that way.
But I think my views are not widely embraced, obviously, by a $28 billion business in a very short time, right?
But I think one of the functions that we've always tried to serve with CancerChoices and, ever since I published Choices in Healing from MIT Press, 25 years ago, integrating the best of conventional and complementary therapies, our hallmark has always been to put out the best information we can find without fear or favor. And if it offended the pharmacology industry, so be it.
Yeah.
And we have the CBD industry, and they may be offended. But let me ask you this. When it changes the receptors, are those changes irreversible? Do we know?
Yeah, no, I don't think so. I think it's just in the presence of the CBD, but I am not a neuropharmacology physiologist or whatever. But I'm happy that when we demonstrated the cannabis website, that we did point out that the evidence that cannabis cures cancer or has any impact on cancer is weak, because that is something that, as an integrative oncologist, pains me to see patients waiting months to see me, treating a potentially curable cancer by taking highly concentrated oils of THC or CBD or the combination, and now their cancer has become metastatic and incurable, because we really do not have strong evidence that cannabis has activity against cancer. I mean, the best evidence comes from the test tube, where Manuel Guzman in Madrid studies the impact of cannabis on metabolism. And the brain is the most metabolically active organ in the body. So they would add cannabis to rat brain that they grew up in culture. And they said, maybe we can do our work faster if we do a brain tumor. So they grew up a rat brain tumor and added the cannabinoids, and everything died. They said, oh, maybe we did something wrong. So they did it again and everything died. They said, well, maybe it's a bad batch of cannabinoids. So they went back to the normal brain and everything lived. And since that time, they've demonstrated that when you add the cannabinoids to the brain tumors, that the receptor complexes with the cannabis, and the cannabis tells those brain cells to commit suicide. And they've also demonstrated in the culture, in the test tube, that cannabis blocks vascular endothelial growth factor, which allows new blood vessels to form to feed a tumor, which is how bevacizumab works, a very expensive pharmaceutical. And they also demonstrated that cannabis blocks the activity of an enzyme called matrix metalloproteinase 2, which allows cancer cells to become invasive and metastasize. So all that happens in the test tube, but none of it has yet translated into impact on humans.
Now that's extraordinary. I have a note here from our colleague, Steve Heilig at San Francisco Medical Society, who's also a senior advisor to Commonweal and has worked extensively with us. And Steve says, beyond his pioneering contribution to integrative cancer care, Donald has also been a real force in helping give people access to the right to die. And he said that many of us see as a great contribution to patients' peace of mind and quality of life. And he actually put up a link to a conversation he had with you about that. So could you just say a little about how you came to, and what, when you think about your life work, these different areas in which you've pioneered, how important is this focus on enabling people to have the right to die and to have the peace of mind that goes with that?
Yeah. Let me just finish my cannabis thought by saying I also agree that it is very useful for symptom management. And I love it for patients because it deals with nausea, vomiting, loss of appetite, pain, depression, and insomnia. So when I was a young AIDS doctor in the 80s and 90s, before we had effective therapies, young, previously healthy, very energetic men, attractive, contributing to society, were dying. And they saw, by watching their friends go, what lay ahead of them. And they said, you know what? I don't want to do that. And so when it was not legal or anything, I became a person who would write the prescription for the potion, if you will, that would allow patients in their, own way to orchestrate their death and not go through that terrible end of life death. Unfortunately, my own partner that I mentioned had that access, but became demented and wasn't able to use it himself, so spent his final days in hospice. But gee, going through that AIDS crisis and watching men become so diminished and, so much pain at such a young age, demanding that they have access to, some ability to end their life with grace and dignity, just made it clear to me that we need to do that. I will say that as an oncologist for 39 years, the number of patients who have asked me for assistance compared to the number of young gay men in the 80s and 90s is, I can count on one hand the cancer patients who've asked for that. Whereas, maybe it's because of the difference in demographics that these people were 30 years old and these people are 60 or 70 and are more, willing to undergo that. I read a wonderful book called A Matter of Death and Life by Irv Yalom and his wife, Marilyn, who was diagnosed at age 86 with multiple myeloma and didn't want to go through treatment. And Irv is a psychiatrist at Stanford who's written many books about psychotherapy as well as many novels. And Marilyn is also in her own right an academician, a historian of French literature and art, I believe. And she asked him to write this book with her. They alternate chapters as she's diagnosed and dying and ultimately chooses to end her own life with assistance. And it's a very powerful, very beautiful book, I thought, very poignant.
Well, Donald, and I'm so glad our colleague Steve Heilig raised this, because this happens to be one of my personal areas of true passion, and I really get the complexity of the issues. And of course, we know that American society, just as it has embraced cannabis and is embracing psychedelics, which we might also talk about, is embracing compassion in dying. So there are these cultural movements that are spreading across the country. I happen to believe, I take honestly a quite radical view of this, that people ought to have the right to die under any circumstances, that they shouldn't be limited to, 6 months. So I happen to take what is honestly a radical point of view, although there are philosophers who say that the right to die may be one of the best indicators of the true freedom of a civilization. So we won't go into the depth of those issues. I know that some people interpret their religion as saying it's a sin. I know that not only Catholics, but some Buddhists feel very strongly that you shouldn't ever do that. There are a wide range of very credible views, and it's a very complex question what should be legal. But my goodness, what courage it took that you were willing to write those prescriptions for people at a time where there was real risk in doing that.
Well, we actually wrote an article in the New England Journal of Medicine. At the time, I was also the leader of a group of physicians in the Bay Area and 9 Bay Area counties, the Community Consortium. And we did research in those days, there were private practices. I had a group of nurses that would go out and do research. And we did a survey of Community Consortium practitioners. I think it was about 100 people. And we gave them a test case and said, would you assist this patient? And then we asked them, how many of you have assisted people in your practice? And that number was 54%. And that was published in the New England Journal of Medicine in that article.
Well, I remember a New England Journal of Medicine article many years ago. I think it was when I was researching Choices in Healing from MIT Press, where a really distinguished physician said that it was precisely the ability of medicine to help people live high quality lives for longer periods of time that meant that at the end, sometimes they would suffer more because they had been, they'd been kept alive in ways that when the end came, there was the possibility that it was going to be more difficult. And therefore, this person argued, there was an ethical obligation to help people, end their lives precisely because medicine had enabled them to live longer. Now, I don't know whether that was just one point of view or whether it not, but it stands out in my memory because the argument was such an interesting one. You help people live longer. It gets more complicated at the end. You should be able to help them depart.
Well, in view of what you said about being radical and wanting more than just a 6-month lifespan to allow people to have that choice, certainly as I age, dementia is something I really fear. I've had parents and step-parents all became demented and institutionalized at the end of their life. And it's no, thank you, but unfortunately that's not included in the opportunity at this point in time.
No, I know. And those are the fundamental questions. I'm so glad we're talking about this because those are the fundamental questions that people with any disease, cancer or anything else, face, whether it's cancer or dementia or something else. Do I follow the law here, which we'd all like to follow? Or do I believe with John Stuart Mill in a fundamental principle of English jurisprudence, which is that we have the right to decide what we do with our own bodies? It's a very fundamental question.
We probably don't want to go there with the current Supreme Court,
Well, probably not. Probably not. So I want to come back to the cannabis question because as you've said, you think the real medicine is the whole plant, and you make a cogent case for that. But you go into, if you're in a state that permits the sale of cannabis, you go into a cannabis store, and there are 50 different varieties. So if a patient asks you, how do I choose among all these varieties, by the way, many of which are not the original sort of organic cannabis plant. They've been, evolved in different directions. So how do you guide a patient who's trying to figure out which variety of the whole plant to use?
Yeah. So my husband, as you know, Clint Werner, wrote the book, Marijuana Gateway to Health, How Cannabis Protects Us from Cancer and Alzheimer's. And when he hears me telling patients when I do clinic from right here in my living room, and he's back there in the end of the house, telling them, go to the dispensary, ask the bud tender what works. He said, honey, stop telling people that you sound like an idiot. You're asking them to ask people that don't even have a college education. I said, well, what else? I don't know what's in the dispensary, and I don't know what works. So a few years ago, 2 PharmD graduates from UCSF came to me and said, what would you think if we opened a dispensary? And I said, yes, that would be great to have pharmacists running a dispensary. Well, they came back a year later and said it cost $1 million down. So instead, we've opened a cannabis concierge service platform. And so it used to be called Med1 RX, and they've changed it because Med1 was the name of a bigger company and people got confused. I think they're now calling it B Heracles, BE Heracles. For years, they've been trying to get me to be a paid consultant to the company, but they haven't figured out the legal aspects of that. So I have no financial input or gain from mentioning their name, but I do refer patients to them. And my patients, particularly older folks who don't really want to go to a dispensary and don't want to be overwhelmed by all those choices, really enjoy working with Matt, who's the pharmacist who runs that show. And, he generally recommends a tincture that he thinks would be best after talking to the patient about what it is they're trying to treat, what other medications they're on that might interact with whatever he's going to recommend, and sometimes can even facilitate having the product delivered so that the patient skips the dispensary altogether. So, other than saying, go to the dispensary and ask the bud tender, I now have an option to refer people to this service, which should be more widespread and available. There are some states where cannabis is legal as medicine that the dispensaries do have pharmacists there on site to help with that situation. But the true answer to the question is we don't know, because nobody's studied all those strains for particular indications. So, that's why I say, well, those people are on the front line, those bud tenders, and they must know that the patient came back or the person came back and said, this didn't help me at all for sleep or nausea. This did. So maybe they put two and two together and can help inform another patient. But meanwhile, I like working with the PharmDs who seem to be more credible, perhaps.
I love the phrase bud tender. I'd never heard that before.
Oh, yeah, that's what they're called. Yeah.
Steve Heilig again says, most hospice patients I've seen who have asked for assistance in dying don't actually use it. That's a key point. They just want the assurance.
Yeah.
I've come to believe it actually extends life more often than not. Ironic question mark. Yeah, I think that's really interesting.
Well, no, it's very similar to the studies that have shown, for example, in lung cancer and other cancers, that patients who have earlier involvement of palliative care teams actually survive longer too. We think of palliative care as hospice, and that if we're sent there, that's the end of the line and we're not going to do anything else. Well, those people who get consulted by palliative care physicians actually do survive longer, ironically.
Yes, I find that a fascinating finding, and I'm familiar with it, that people who at a certain point decide to stop active treatment and go on palliative care often live longer. I find that absolutely fascinating. And it's also fascinating, as you know, that some places are now beginning to integrate palliative care and active treatment so that you can be in palliative care and continue active treatment. It's very interesting.
You can be in palliative care, but not in hospice.
Exactly.
Yeah.
Here's a very interesting question that's worth discussing. What about Rick Simpson Oil? Now, that's a really interesting question because I know how you're going to respond to that, but I want everybody to hear.
Yeah, well, I like to call it full extract cannabis oil as opposed to assigning it a name of a person. And again, this is a highly concentrated oil of cannabis that patients think might cure their cancer. And I have not seen evidence that it has that impact. And in fact, the directions are to increase the dosage to the point where the amount of THC that a patient is consuming is quite huge. And I've seen people that can't get out of bed and don't eat anymore because they're trying to follow this protocol, which is, not something that I generally believe in at all. And I dissuade people from using it. Mm-hmm. One other thing to note is that cannabis, is a medicine, and like other medicines, it's broken down in the liver, and its components can also impact the enzyme system in the liver that breaks down other medications, pharmaceuticals, for example. So particularly CBD inhibits the enzymes in the liver that break down pharmaceuticals. So people taking highly concentrated full extract cannabis oil, either high in THC or CBD, need to be very careful if they take pharmaceuticals, because especially if it's a high CBD product, that will inhibit the enzymes in the liver that metabolize pharmaceuticals, allowing them to build up in the bloodstream and become more toxic.
Yeah, these are critical questions. And I wish everybody could hear you, Donald. Because here's the thing, people think, at the one end of the spectrum, there are the things that we can say, these 7 healing practices are going to make you healthier and live longer, better quality of life, and they may extend life as well. And we can say to people, guess what? There are actually studies that show that palliative care sometimes extends life as well. But then we get to cannabis and we get to CBD and we get to, which THC products or which whole plant products are the best? And you, as the leading expert, say we don't actually know. And the point is that the complementary therapies are a frontier of treatment, just like conventional therapies. And the information keeps going forward. So there's immense subtlety to many of these questions.
Yeah, well, the cannabis question, the reason that we don't know, I might add, is because the barriers to studying the therapeutic benefits of cannabis are huge. The only legal source of cannabis for research in the country used to be the National Institute on Drug Abuse, NIDA. And as Alan Leshner, the former head of NIDA, told me, we are the National Institute on Drug Abuse, not for drug abuse. So NIDA has a congressional mandate that they can only study substances of abuse as substances of abuse. So if you want to look at the potential therapeutic benefit of the plant, you must use NIDA cannabis up until very recently, but they cannot fund such a study. So they spend $150 million a year looking at the harmful effects of cannabis, of which they can find really very few, but they cannot fund research to look at the potential benefit.
Yeah, it's extraordinary.
That's why there's such an absence of evidence.
We have a wonderful question from Deborah. This is how important these questions are. She says, I will be starting immunotherapy next Friday and just read that cannabis use for symptoms is contraindicated during treatment because of immune checkpoint inhibitors. Most articles I read pointed to a study in 2020, though, so I am hoping this is not really the case. I am very worried because my use of cannabis is the only way I know to keep my appetite up and my sleep sound. So that's a very interesting question.
So the data that she's quoting and that's driving this discussion, it comes from Israel. Israel has been really at the forefront of observational research, because any patient getting medical cannabis in Israel gets a license, and that license allows the government, I guess, or the investigators to survey the patients and follow their outcomes. So what they found, the first report was that patients using cannabis with immunotherapy compared to patients getting immunotherapy and not using cannabis, the patients using cannabis had less positive outcomes of the immunotherapy, but there was no difference in survival. And that was followed by another study, 68 patients getting immunotherapy compared to 34 getting immunotherapy and using cannabis. And again, this is not randomized placebo controlled, this is just observational. So this study was amazing in the difference in that the patients using cannabis with their immunotherapy had a much shorter duration of the response to immunotherapy and had 2 years shorter survival, 6 months survival compared to 2.5 years. And I said, how is that possible? So I looked very carefully at the differences in those two groups because it wasn't randomized. And there was a statistically significant difference in that the patients not using cannabis were getting immunotherapy as first-line treatment significantly more frequently than the patients using cannabis who were getting it as second or third-line treatment. So perhaps it was the line of therapy that was dictating the worst outcome and not the cannabis. However, since we don't know that, I often inform my patients starting immunotherapy about these results and ask them to make their own decision.
And that leads us to an observation of yours that I quote so often, Donald, about how to evaluate complementary therapies where what we say at best may be science informed, but it's not scientifically demonstrated. And you have this wonderful line, which I haven't heard others use, which is, if I say it correctly, the lower the evidence of harm, the lower the burden of proof. Now, do I have that right?
Yeah, so it's actually something I stole from Andrew Weil.
Oh, really?
Yeah, that says the degree of evidence should be directly proportional to the potential for the intervention to do harm. So if I say I'm going to give you this new chemotherapy and your hair is going to fall out, you're going to vomit for 3 days, and your bone marrow is going to be suppressed, you're going to say, show me the evidence that it's going to benefit me. But if I'm going to tell you to eat more blueberries and broccoli and get a massage twice a month, how much evidence do we really need for that?
Right. And let's pile on top of that the power of the placebo effect.
Yeah. So two things there. There's a paper I haven't yet read. A placebo was given to patients with cancer fatigue, and they were told this is a placebo. And in 1 week, their fatigue was improved. A study that I'm putting in my presentation next week on the pain study was patients with pain got placebo or CBD, and they were told it was placebo or it was CBD. So the placebo recipients who were told that they got CBD had more pain relief than the people taking CBD. And that's expectancy. And if the placebo effect, if it works, how can we argue with it?
Well, it's so strange that we call things placebo, because that suggests that it's kind of a fake effect, But if we think of it as your innate healing ability, when you have an intervention that somehow, even if it's called placebo, makes you feel better, right? There's this incredibly powerful innate human healing ability that is released.
It's the mind-body connection, right?
Exactly.
Yeah.
Exactly. And if we think about pharmaceuticals or conventional care, they have immense placebo effect. I mean, here you have an authority telling you this is what is really going to help you. The placebo power of conventional therapy is at least as great as the placebo power of complementary therapy.
Yeah, I think antibiotics and anti-cancer agents are probably not placebo, though. I think they might work. Yeah.
Yeah, that would be an interesting question to follow up. So, we have Julia Rowland on the line here.
Oh.
She's just telling us that Steve Heilig's link doesn't work. Hi, Julia. It's such a pioneer of complementary therapy research. I remember Julia telling me that of all the different therapies that have been researched on the complementary side, that exercise was the single one for which there was the most evidence. Does that resonate for you?
Sure. Yeah. So I'm a big believer in the American Institute for Cancer Research, World Cancer Research Fund recommendations for reducing the risk of cancer. Number 10 says for cancer survivors, follow the 9 guidelines above. And number 1 is to be a healthy weight. Mm-hmm. We now believe that 40% of all cancer in the United States is related to overweight or obesity. And the second one is to be, currently it says move more, sit less, which I think is less prescriptive than the 2007 guideline, which said be physically active for 30 minutes each day. And I think the evidence is really quite clear that physical activity decreases the risk of breast, colon, and prostate cancer, and that patients with a number of cancers, including those 3 plus also pancreatic cancer, who are physically active do much better with regards to survival than people who are not physically active. And we also know that patients would like to hear about physical activity or be told to be more physically active by their oncologist. And even though 50% of oncologists believe that that's a good thing to do, very few actually do it because they don't have time. They're treating the cancer and not the patient living with cancer. Mm-hmm. A recent study came out and showed that people who are sedentary, And people have become much more sedentary since the pandemic because they're in their house, who do not exercise for 150 minutes a week have a 5-fold greater risk of death than people who are physically active, who exercise 150 minutes a week, and who are not sedentary.
That's only 20 minutes a day.
Yeah, or 30 minutes 5 times a day, a week.
Mm-hmm.
Yeah, it's whatever. But that's 5-fold increased risk of death is pretty profound. Mm-hmm. So I think people need to get out and exercise and move. And that's absolutely correct. Mm-hmm. And I believe it should be aerobic. So something that gets your heart rate up and in fact makes you sweat, as well as resistance, because so many cancers like to go to bone. And I think resistance exercise not only keeps the muscles toned, but the bones mineralized. And then I discovered late in life the benefits of yoga, which is strength, flexibility, and balance. And those are all things that we need as we grow older. But in addition, I always say Jewish boys can't meditate. But at the end of a 60 or 90-minute yoga class, when we do Shavasana, the corpse pose, and they say, you can come back now, I feel like I've gone someplace.
That's
so
wonderful.
For me, yoga is a good mind-body intervention, as well as strength, flexibility, and balance.
Laura Pohl, you have been listening to this. You have a wealth of experience. Any reflections on what Donald has been telling us?
Well, I'm taking furious notes because every time I hear Donald speak, he tells me something that I know we need to put in Cancer Choices. I was just wondering, because I know over the years, and this is a little bit apart from what we've been talking about, but Donald had some influence with SIO and other integrative oncology groups in talking about what we used to call the CAM therapies, complementary and alternative medicine. And then Donald talks a little bit more, since we're talking about integrative oncology, the distinction between, is it CAM or are we talking about complementary therapies? And I wonder if Donald might want to speak a little bit to that distinction, since that's a huge part of what we're trying to impart to people through Cancer Choices.
Great point.
Yeah. So CAM was a lovely acronym, easy to say, very popular 20 years ago, but something cannot really be complementary and alternative at the same time, because complementary means we're doing it in conjunction with conventional cancer care, and alternative means we're doing it instead of. So I think CAM is a lovely acronym, but it's internally self-contradictory. So what integrative medicine is integrating complementary and conventional, and not using the alternative word at all. I mean, I think 5% of the people I see in my practice are looking for alternatives to conventional cancer care. And I say, I don't have any magic bullet in this drawer. When I used to work in my office next to a dresser that had drawers, I said, if I had something that was alternative that worked, we'd be using it. I say, I'm an oncologist for 39 years, and I know what I do can have some benefit. And there's nothing out there that's truly alternative. And I see people, again, with the full extract cannabis oil, with intravenous vitamin C, with mistletoe, looking for alternative therapies that, I caution them that it's a waste of time, in my opinion. Those people that go down to Mexico or go to Switzerland for these clinics where they offer all sorts of intravenous therapies, I just haven't seen them work from my perspective or vantage point. So what we do in integrative medicine is integrate complementary and conventional. And thank you for mentioning SIO. I did want to bring up the Society for Integrative Oncology, especially Julia Rowland on the call from the Smith Center, and working with the American Society of Clinical Oncology, which is our conventional oncology group. What we're doing now is the Society for Integrative Oncology is mainstreaming by working together with the American Society of Clinical Oncology, or ASCO, to develop guidelines. And Julia asked me to participate in her committee, which was looking for symptom management. Actually, I wound up leaving that committee because ASCO asked me to be on a committee making guidelines for cannabis use in cancer patients, updating their previous guidelines saying that the cannabis-based medicines should only be used in refractory nausea and vomiting, and that there's not enough evidence to support the use of marijuana in the situation. So hopefully, as we're working on new guidelines, we might move that one a little bit forward. And the reason I point out the ASCO-SIO interaction is that the Society for Integrative Oncology, now 20 plus years old, is collaborating with other organizations to help bring integrative cancer care into the spotlight a little bit more.
Yeah,
that's important.
Which is critically important because the ASCO, the American Society of Clinical Oncology, is the establishment oncology community. And the fact that the Society for Integrative Oncology, which Donald also headed at one point, if I remember correctly.
Yeah, 2010.
Really is sort of the group that is interacting with the mainstream. So these are important developments. But I think it's also important to say that the Society for Integrative Oncology has become quite mainstream in a good way, getting leadership from people at Sloan Kettering and elsewhere. And so its approach to integrative therapies is quite conservative, I think it's fair to say. So it seems to me there continues to be a need for many people who may also play a role in that part to continue to push the envelope further in the exploration of the new frontiers, which go on forever, of integrative care.
Yeah, no, you are correct that the Society for Integrative Oncology is a bit conservative and very research-oriented and research evidence-based. And, that evidence-informed is a little gentler and a little more useful for patients to have evidence-informed data as opposed to hard evidence-based from randomized placebo-controlled clinical trials.
I'm going to ask Nancy Hepp to come back on. And while she does that, I'm going to read a note from Julia Rowland. The history at the NIH, National Institute of Health, is that they first established an Office of Alternative Medicine, which then became the National Center for Complementary and Alternative Medicine, which is now referred to as the National Center for Complementary and Integrative Health. So it's good to have that. Nancy, as you have listened to this, as the person who really has done a heroic job of getting CancerChoices.org up, and both lead researcher and just the manager of the whole process. Any reflections on what you've heard Donald say?
I think that, yes, there's a spotlight on the evidence base, but then the broadening, as Laura mentioned earlier, let's look at what all of the different types of evidence that are available. We want to know if there's good, solid, clinical-based evidence, but we expand that because we know there are other types of evidence. And people with cancer need to know all of the options that are available.
Mm-hmm. Nancy, I'm glad you said that, because our colleague Wayne Jonas, who's Donald knows well, who's been another pioneer of the field, he talks about, Donald, the house of evidence, saying rather than look at randomized controlled trials as the single gold standard, they're not always the most appropriate standard. Do you agree with that? Do you see it as a house of evidence?
Yeah. There's a hierarchy of what, because I've been on that committee from the National Academy of Science, Engineering, and Medicine that wrote the health effects of cannabis and cannabinoids. And I learned a lot about how we rank evidence. And again, the randomized double-blind placebo-controlled is at the top, followed by this, that, case studies, observational studies. I mean, the observational study from Israel that suggested that cannabis should not be used in patients getting immunotherapy is an example of why that might not be correct. Maybe it's not the cannabis, maybe it's the fact that those people who use cannabis were getting the immunotherapy as second or third line evidence. So you have to be a little bit cautious. And again, I am not demanding evidence-based. I like evidence-informed. I did want to say one thing about the website or the
Yes.
booklets. I don't know if we're going to talk about the booklets.
Please go ahead.
But I did want to, Nancy, maybe you can talk about some of the handbooks or demonstrate the handbook.
Certainly. Let me pull them up. So we have a collection, and it is growing in that we're planning many more of integrative cancer care handbooks. And we have brought forward from beyond conventional cancer therapies, which was our previous iteration, these 4 handbooks that go in depth on what do we know about what promotes healing and wellness and better outcomes among breast cancer, colorectal cancer, ovarian cancer, and prostate cancer. And these are extensive. The breast cancer one is, I think, 118 pages long. So they're not for the faint of heart. We will be redoing them so that we will have that overview at a glance for people who that's all they can take in right now. And we will also be looking at various timestamps. So throughout your cancer experience, from the moment you hear the words, you have cancer, up until the very end of your life, what do we know is beneficial? What do we know is beneficial while you're in active treatment? What do we know is beneficial while you're in remission? And so on. So we will be portraying things in a way that we think will be more meaningful for people. But in the meantime, these handbooks are available for people. We also have handbooks specific to certain types of treatment. For example, the surgery handbook goes into great detail of what you can do as you're preparing for surgery to lead to better outcomes. What should you be doing on your surgery day? After surgery, what can you be doing and what can you be taking to improve your outcomes, and so on.
Thank you, Nancy. Donald, this has been extraordinarily beneficial. Any final thoughts and reflections on apologizing for my tech issues?
No, I just want to congratulate you on this new website. It's really, I think, a valuable resource, not only for people living with cancer, their caregivers, but also for professionals, healthcare professionals to, again, as we started out saying, to make integrative oncology more accessible to all.
All right. Well, it looks like we've lost Michael. I wonder if anyone who's joined us on the webinar would want to ask Donald any questions. If you want to, feel free to put those right in the chat, and he's still here. He can do some question and answers.
And for Nancy, what might be the timeline for head and neck and lung cancer handbook to become available?
A great question. So the way we are building all of our handbooks are based on the foundation of what we find when we put out the therapy reviews. So we build out the therapy reviews. We're just finishing our 30th complete, exhaustive review of a therapy. Once we have that information base, then we populate the handbooks. And so we feel that 30 therapies is sort of a critical mass that we can start building the handbooks for the different cancer types. And so those can go very quickly because we already have all the information assembled from the therapy reviews. So I am hopeful that we will start having therapies, summaries, and handbooks for specific cancer types by the end of this year.
This is Laura. I remember an interesting presentation you gave. It may have been on when we did the one for SIO on prostate cancer, but you were showing the difference between what physicians look for in terms of evidence and what patients look for. And I was wondering if you could contrast and compare that a little bit.
Yeah, so that's a slide that I used from an old study that was done in the UK, where they looked at 32 men with prostate cancer, and they asked them what drove them to select a particular complementary therapy. And the number one was recommendation from friends and family. And number two was the enduring duration of that therapy. And then there was 3 and 4. And number 5 was scientific evidence. And so I use that, to inform my oncology colleagues who are so evidence demanding that our patients often have a different hierarchy of evidence. And, in those days, that was prior to social media, whatever it's called, Facebook and tweets and all that, which makes you get your advice now from more than just your friends and family, but from unknown people that who knows who they are or what their motivations are. So I think it's important for us to appreciate that patients are not necessarily going to scientific evidence as their first choice of what prompts them to use a particular complementary therapy.
Someone wanted to know specifically about finding an integrative oncologist in the San Francisco Bay Area, but I wonder, I don't know if you'll choose to address that specifically, but maybe some guidelines on helping. How do you advise people to find help in putting together an integrative cancer treatment plan?
Yeah, again, as I mentioned at the beginning, there just aren't enough integrative oncologists to meet the demands. So, I think that the work that you all are doing, this website, Anti-Cancer Living, I am a paid consultant to a website called Well Casa, which looks at potential interactions between supplements and pharmaceuticals, and looks at I've been doing some videos for them on, different supplements to treat different aspects of living with and beyond cancer. So again, in the spirit of full disclosure, I am a paid consultant to Well Casa, but I think they are also there, similar to the work that we're doing here, to help make integrative cancer care more accessible to people who want it. I always point to the 4-part series that Michael and I did at Commonweal years ago as a real valuable resource for people that want guidelines in integrative cancer care. Even though we did that, I don't even know how many years ago, I think it's still pretty relevant. People often ask me, do you have any updates? And I don't think I do. I think it's still relevant, that 4-part video series.
Yeah, Donald, I keep cutting in and out, and my apologies.
That's okay.
But I really just want to thank you so much for this extraordinary conversation. It's been wonderful. We look forward to ongoing partnership and your wisdom as one of our advisors. And really just thank you for your extraordinary leadership in the field.
My pleasure.
Yeah. Kira, back to you.
So just another reminder, that we're going to have the recordings from the whole conversation today. They should be finished and produced in about a couple of weeks. They'll be on the CancerChoices.org website, and they'll be on the New School website and on all of our media outlets, SoundCloud, Apple Podcasts, Spotify, and YouTube. And I think I wanted to point out that we have another event coming up that will be interesting, I think, to people on this webinar. This is going to be something that we just put together. It's a walkthrough of the Cancer Choices website, and that's going to be Wednesday, August 3rd from 9 to 10:30. You can find that on our website as well. And we hope to see you at the next event. Thank you so much for joining us.
Donald, thanks again. Extraordinary. And thanks to all who've listened in, and to Nancy Hepp and Laura Pohl and Kira Epstein. Thank you all. It's been extraordinary.
Don't take it, don't, don't. 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 Don't take it, don't, don't.